All right. Hello, everyone, and welcome. Again, my name is Jamie Singletary, and I am here with the lovely Chrissy Stockard, who I will introduce in just a moment. But I did want to take a minute to just go over a few housekeeping items. This is the first CE presentation of the summit. And so, in order to receive your continuing education credit, you will need to be logged on to this presentation live. If for any reason you have any type of technology issues or you need to log off, please don't hesitate to email me as I will put my contact information in the chat. Also, your CEGO dashboard is going to be the best place for you to stay on top of the schedule, along with completing the evaluations for your CE certificates. At the end of the summit on Friday, you will be able to download all of the hours that you have earned over the next 4 days. So we will not be providing certificates day by day, but at the completion of the summit, you will be able to get your certificate. So with that being said, it is my pleasure to introduce my friend, my colleague, Chrissy Stockard. Chrissy is the Chief Health Officer at Within Health and is coming to you from sunny and warm Florida. Is it sunny? I know we're on the heels of another
Not
one.
not so sunny today. It's a little rainy.
Okay, she's coming to you from not so sunny Florida today, but in on any other day, she's a ray of sunshine. So wherever Chrissy is, it's sunny. Chrissy's journey in healthcare started after a career as a teacher, and she still loves to bring education into the work she does every day. After becoming a nurse in 2010 and working in various specialties, she found her passion and dedicated the past 12 years to specializing in the field of eating disorders. She feels honored every day to work in this field and with this population. Guiding individuals toward recovery is both her mission and privilege. Beyond her professional endeavors, she is a proud mother of two wonderful children. She loves to go to their school, and you'll hear a little bit about that later. Plays and cheer at the soccer game when she's not chasing around her little ones. You can probably find her baking or frying, reading, walking, and lovingly, yes, she is a nerd at heart doing a crossword puzzle. And the reason I have this banter with Chrissy is because we went live. We were talking about just the things that we do, and she lifted up her hands, and I'll turn it over to you, Chrissy.
Good morning, everyone. And thank you so much, Jamie, and thank you for having me, and welcome to the 2024 Within Health Summit. Before I get started, I do feel like I just have to put this caveat in. I talk a lot with my hands, and if you see them, they are all wrapped up right now. And it's because this morning, part of my son's school project was for Hispanic Heritage Month. They were doing Spain, and he was in charge of food. And I thought it would be a great idea for us to make some churros. Well, turns out when you heat the oil up high enough, it can kind of explode and splatter all over you. And well, that happened to me this morning. So my arms are all bandaged up. You can kind of see it on my neck. It kind of got everywhere. I'm good. We're going to move on, but the things we do for our kids. So anyway, thank you, Jamie.
You're welcome.
All right, I am going to share my screen and we will go ahead and get started. So, like Jamie said, my name is Chrissy. And this morning we are going to be talking about eating disorders and how they are often stereotyped in the medical field. And then how we as providers can help to combat the stereotypes and how to equip our clients when they are going to see a medical professional. So one of the things that we know is that eating disorders are deadly. Unfortunately, those of us who have worked in the field long enough have seen this firsthand. And yet eating disorders are often underdiagnosed, misdiagnosed, or in some circumstances are actually praised by the very providers who are supposed to be helping our clients get better. And while there have been some small shifts in the medical field recently, so for the most part, individuals with amenorrhea are no longer being prescribed oral contraceptives to protect their bones. The medical field still has a long way to go and needs our help. So today, we are going to be looking at common biases related to eating disorders that are seen in the medical field, ways in which we as clinicians can help to advocate for our patients, and ways in which we can support our clients in advocating for themselves in the medical world. Why is this such a big deal, you ask? Because the statistics with eating disorders don't look good and don't provide compelling evidence that we are doing enough to combat them in the medical profession. We're going to review some statistics that a lot of you are probably familiar with, but it's important to keep them in the forefront of our minds when we look at biases and stereotypes that our clients face every day. So statistic number one, well, I guess this is comment number one with statistics below it. Eating disorders come in all shapes and sizes. So only 6% of people with eating disorders are medically diagnosed as underweight. And yet, one study found that providers are more likely to perceive eating disorders as less severe and recommend less intensive treatments for larger bodied individuals. Observed examples of this in practice include prescribing lower calorie, more restrictive meal plans to larger bodied patients, or offering combined treatment for binge eating disorder and obesity. When combining those two treatments conflates recovery from an eating disorder with goals and activities that may have actually contributed to its development. In another study, Deb Burgard, a fat-positive clinician and activist, astutely noted, "We find it hypocritical to prescribe practices for heavier people that we would diagnose as eating disorders in thin ones." We also see that 3 out of 4 women in the United States have disordered eating. This can include frequent dieting, anxiety associated with specific foods, meal skipping, chronic weight fluctuations, rigid rituals and routines surrounding food and exercise, feelings of guilt and shame associated with eating, preoccupation with food, weight, and body image that negatively impacts quality of life, a feeling of loss of control around food, including compulsive eating habits, using exercise, food, restriction, fasting, or purging to make up for bad foods consumed. Disordered eating means these individuals have not been diagnosed with an eating disorder, but they can still experience significant consequences like bone loss, gastrointestinal disturbances, electrolyte and fluid imbalances, low heart rate and blood pressure, increased anxiety, depression, and social isolation. And yet, these behaviors are being praised and encouraged by the medical system because the majority of providers still think thinness equals health. We also see that when BIPOC individuals are affected by eating disorders, though BIPOC individuals are affected by eating disorders at similar rates overall as their white peers, they are about half as likely to be diagnosed. This is reinforced when BIPOC patients with eating disorders and weight concerns are significantly less likely to be asked about eating disorder symptoms by their doctors than are non-minority patients. In one scenario, a different group of clinicians were presented with the same scenario. A 16-year-old female named Mary. Her clinical presentation of disordered eating behaviors was the same for each clinician group, though her race of Black, white, or Latina was different in each group. Clinicians were asked to decide if Mary had an eating disorder and if they would refer her for treatment. When Mary presented as white or Latina, she was more often diagnosed and referred for treatment than when she presented as Black, when in most cases, providers failed to diagnose the eating disorder at all. We also see that eating disorders start young. 40 to 60% of elementary school girls ages 6 to 12 are concerned about their weight or becoming too fat. 81% of 10-year-olds are afraid of being fat. And in a recent study, over 50% of females between the ages of 18 to 25 would prefer to be run over by a truck than be fat, and 66% of those surveyed would rather be mean or stupid. Let those statistics sink in for a minute. The youth in our country are getting bombarded with messages about thinness all the time, to the point that they would rather be run over by a truck than be fat. They get messages about thinness from media, from their friends, from their parents, from their siblings. And in most cases, in most states, our kids are actually publicly weighed in schools. In the case of my daughter, it was in the cafeteria. And then a report card is sent home to parents about their weight. As parents, we are not given an option to consent to this practice. We can only read the fine print and opt out if we are lucky enough to catch the message about it buried deep within the thousands of other pieces of paper that are sent home with our kids. It's a cause for anxiety and directly causes bullying within schools. And then they hear about weight from their doctor. No wonder they're terrified. We also see that eating disorders are widespread. Eating disorders affect all races, all genders, and all sexual orientations. Eating disorders can be diagnosed in children as young as 5 years old and continue to affect people over the age of 80. In a sample of an American emergency room, 16% of adult patients screened positive for an eating disorder. To put this into context, the average emergency department physician sees between 3 and 20 patients per shift. This number can vary based on size, location of the ER, but that's a good average. If 16% of people who walk into an ER screen positive for an eating disorder, that means that the average ER physician is seeing 1 to 2 patients every day that meet criteria for an eating disorder. Or put another way, the CDC published that in 2021, there were 139.8 million visits to emergency departments. This breaks down into 383,000 visits per day throughout the country. That means that about 61,000 people a day visit an emergency department that meet criteria for an eating disorder. But I definitely do not think that 61,000 people a day in our country are being diagnosed. And just for reference, about 6 to 7% of people go to the emergency room every year for chest pain. We also see that eating disorders are deadly. It was estimated in 2018 and 2019 that each year about 10,200 deaths were directly related to an eating disorder. This is equivalent to 1 death every 52 minutes. So while we sit here today and talk, another 2 people could die as a direct result of their eating disorder. The severity and number of individuals with eating disorders is also increasing. Eating disorders are on the rise worldwide. Between 2000 and 2018, the prevalence in the general population has more than doubled worldwide, from 3.4% to 7.8%. In the US, in just the 4 years that followed, from 2018 to 2022, health visits related to eating disorders more than doubled among people under the age of 17, and visits for all eating disorders among the general population increased by 107.4%, from approximately 50,000 visits in early 2018 to over 100,000 visits in 2022. So now that we know and have revisited the gravity of eating disorders based on the statistics we just looked at, we're going to look at how these are realized by some of the biases we see in the medical field. The idea that individuals are treated differently based on size, gender, sexual orientation, and socioeconomic status is not a myth. It happens every day in the medical field. When reviewing multiple studies on biases in the healthcare field as it relates to eating disorders, the following biases and stereotypes have been identified. 1, someone overweight with an eating disorder must have binge eating disorder. The following information came from research specifically on biases in healthcare on youth with disordered eating, but I do think that it would be fair to extrapolate that the same would hold true for adults. In this study, healthcare professionals often wrongly assume that if a youth in a larger body has an eating disorder, this eating disorder is binge eating disorder, overlooking the range of disordered eating behaviors that could be present, such as restricting or compensatory behaviors. In fact, in youth living in larger bodies, subclinical eating disorders have often present as dieting, fasting, or other weight control behaviors that have often been suggested or pushed upon the patient by that very provider. That provider may then initially assess these behaviors as adherence to weight management recommendations. However, with further assessment, these behaviors and their associated cognitions may provide a more complete understanding of an individual's negative thoughts and feelings about their body, as well as maladaptive behaviors used to induce weight loss. We also see a bias that weight alone is the biggest health risk. Primary care providers may frame weight as an urgent health risk without an awareness of their own implicit weight bias and inadvertently do harm. These experiences of weight stigma in persons in larger bodies results in stress and mistrust of healthcare providers. Additionally, these experiences impact patient engagement, motivation, and adherence. They prevent timely access to care and reduce the quality of care provided. Primary care physicians, who are well positioned to serve as the first line of defense in the screening of eating disorders, may instead inadvertently reinforce a patient's eating disorder by commenting on their weight or praising weight loss. We also see providers think that all ailments are related to weight. In a study with LGBTQ and gender diverse individuals in larger bodies seeking primary care, they described what they refer to as fat broken arm syndrome. Study participants perceived providers as attributing all health concerns to weight and offering weight loss as a solution, regardless of the presenting problem. This is then exacerbated when healthcare professionals often apply a moral medical framing of fat, which blames patients for individual choices and communicates the urgent health risk of obesity, regardless of the presenting complaint. This is a story that I have heard countless times over the year. One patient after another comes through our doors, talks about weight being the only thing that a provider will talk about, even if they didn't come into the office to discuss their weight. We also see the bias that eating disorders look a certain way. Eating disorders and disordered eating behaviors have historically been thought to primarily affect skinny, white, affluent girls, also sometimes called the swag stereotype, resulting in decreased screening and missed diagnosis and treatment of Black, Indigenous people of color, males, and individuals from lower socioeconomic backgrounds who fall into the overweight or obese categories. As we know, eating disorders do not discriminate. They affect all races, genders, sexual orientations, and socioeconomic statuses. And yet, one study revealed that BMI and sex significantly predicted consults. More specifically, women and participants with a lower BMI were more likely to receive a consult for an eating disorder specialist than men and participants with a higher BMI. We also see a bias that eating disorders are just a matter of eating. When individuals with eating disorders were asked about their experiences with primary care providers, they noted that primary care providers not only lacked time and resources to diagnose and treat eating disorders, but were also uninterested in eating disorders, believing it simply a matter of just eating. For individuals with eating disorders, the primary care service was described as an obstacle or a barrier to care, rather than a first port of call or effective gatekeeper to specialist services. In another study, binge eating disorder was perceived to be linked to a lack of self-control and willpower. We also see the bias that individuals with eating disorders are not motivated. A sampling of primary care providers found that some held the belief that people with eating disorders often lack motivation and adherence with treatment, with much of the drive for help seeking and recovery coming from the families. Therefore, some primary care professionals were reluctant to work with eating disorders, with expressions of frustration, resentment, irritability, and disgust in the physical comorbidities, considering eating disorders as being low prestige compared to other illnesses, with some saying they don't like and don't want to work with them. In another study, more than a third of respondents blamed people with eating disorders for their situation and thought that people with eating disorders would be able to pull themselves together if they wanted to. These individuals with eating disorders were also more likely to be associated with personal responsibility than those with depression or a major depressive episode. What we see in these scenarios is that individuals with eating disorders are blamed for their disease and should just be able to eat, whether it's eat more or eat less. And guess what? They're having the same thoughts. The reality, though, is that individuals with eating disorders didn't wake up on Tuesday saying, "Today I'd really like to have an eating disorder." It develops as a coping mechanism for something, and in some instances kept the individual safe and alive. When they hear these messages of just eat or just eat less, it reinforces every negative core belief that they already have and just perpetuates the problem. So what does this look like in real life? I'm glad you asked. Here are just a mere 4 examples of what we have actually seen personally. Number 1, I like to call, "But you're not that skinny." So we'll use the same name. We'll call everyone today Mary. So Mary is a 15-year-old adolescent female with anorexia nervosa restricting type. She's away from home and has been in residential treatment for the last 4 to 5 months. She's completed the weight restoration process and is working on weight maintenance. She also happens to occasionally have very profuse nosebleeds. They're difficult to stop, and in the past, she's had to go to an urgent care to have it cauterized. While in residential treatment, she continues to have nosebleeds, and they've become more frequent. It gets to the point that the medical doctor puts in an order that the next time she has an active bleed, she needs to go directly to an urgent care to have it cauterized because it has to be cauterized when the bleed is active. The day comes that Mary has another nosebleed and she's taken by the residential staff to the local urgent care. Upon arriving, she declined to be weighed because why does a nosebleed require a weight? And informed the nurse that she was in treatment for an eating disorder. This was respected, and Mary thought she was off to a pretty good start. Soon after, Mary was taken into the exam room to be seen, and the doctor came in. Amid her active nosebleed, as she's going through wads of tissues and is very uncomfortable, the doctor asks her why her parents aren't the ones accompanying her to her visit. She let the doctor know that she was in treatment for an eating disorder, so she was here with some of her team. The doctor then stopped what he was doing, looked her up and down, and the next comment was, "But you're not that skinny." Mary had been working so hard to appreciate her new body and had made so many strides, and so much was undone by this comment. Rather than being supportive of Mary and her recovery, he chose to speak based on a stereotype he had in his head, and her team then spent the next few days and weeks working to undo what that doctor said in one sentence. The next one I like to call, "Well, at least you're thin." So now it's a new Mary. Mary is now a 40-year-old female patient with anorexia nervosa restricting type. She has had an eating disorder for the majority of her life and has been in treatment multiple times. Her eating disorder is rooted in childhood and ongoing trauma. While Mary is in PHP treatment, she has to see a series of specialists due to an issue with her foot. After being bounced around to various specialists, she thought she had found someone who would finally be able to tell her what was going on. Unfortunately, that's not what happened. The tests that the doctor performed were inconclusive, and Mary was no further along after her visit with this doctor than she had been before. As Mary was wrapping up with the doctor, as a lovely word of encouragement at the end, out of nowhere and totally unprovoked, the doctor finished by telling her, "Well, at least you're thin." Following the appointment, Mary restricted both her morning snack and lunch, deciding that food was really unnecessary. As you can imagine, Mary didn't remember a single word of anything else that was said to her that day, and only remembered the one sentence at the end. The next I like to call, "You really should lose some weight." Here we have Mary again. Now she is a 55-year-old female with binge eating disorder, and she lives in a larger body. She has a history of bariatric surgery and has spent her entire life trying to lose weight. While in treatment, she has been working for the first time in her life on normalizing her eating patterns. She started eating breakfast for the first time in over 20 years and has been exploring joyful movement. She has been taking dance classes and has been going on walks with her husband. While playing pickleball, another way for her to joyfully move, Mary fell and twisted her ankle. She decided to see an orthopedic to make sure everything was okay. She filled out all of the necessary paperwork, indicating why she was there, and all of the questions she had were related to her ankle. When she met with the doctor, rather than discussing her ankle with her, he only focused on weight loss with her. He dismissed her ankle and the questions she had prepared and told her, "You really should lose some weight." This is an example of fat broken arm syndrome at its finest. And the last I like to call, "Keep up the great work." Mary is now a patient with atypical anorexia. She's in her mid-20s. She was living in what some would define as a larger body, but has recently lost weight, and her BMI is now in the normal range. In order to arrive at where she has been heavily restricting food and exercising excessively. In order to enter treatment for her eating disorder, she had to get a medical clearance completed. She was not hiding her eating disorder from her provider. In fact, she was very forward about it. Upon assessment, she had low blood pressure, a low heart rate, and was losing weight rapidly. She also experienced severe dizziness when she stood up due to orthostatic hypotension. Rather than appropriately addressing the blatant consequences of this client's eating disorder, the doctor was hesitant about clearing her for treatment at all, thinking she didn't need it, and only praised her weight loss and told her to keep up the great work. In all of these cases, the healthcare provider had an opportunity to, at a minimum, say nothing, and at a maximum, work to support the clients in their recovery. Instead, they went in the opposite direction altogether, and each and every time reinforced the patient's beliefs about their eating disorder. This is what we see and hear about all the time. Why is this happening? I think the more apt thing to say is, obviously this is happening because there is an enormous lack of education. In the US, in order for a physician to practice, they need to graduate from medical school and complete their residency training. This process is supposed to be comprehensive, with medical school giving future doctors exposure to all facets of medicine, and residency giving physicians specific training in their specialty. But where's the eating disorder training? In the US, during a 2015 study, 80% of surveyed residency programs did not offer eating disorder rotations. In Canada, which has a very similar process to the United States, medical students receive 3 to 5 hours of education about eating disorders in their studies, and many do not treat any patients with eating disorders during their clinical placement. In a 2022 study of family medicine physicians and residents, several participants mentioned how difficult it can be to identify disordered eating patterns in patients who do not show the stereotypical signs and symptoms of an eating disorder. One resident was quoted saying, "I think a lot of us are taught anorexia is not eating, and then bulimia, and that's pretty much it." So what about our nurses? Surely nurses could get more education on eating disorders, or maybe not. When asking our very own within health nurses what kind of training they received on eating disorders, it's safe to say that it was almost 100% on-the-job training. Our nurses graduated between 2001 and 2016. Some graduated with associate degrees in nursing, others with bachelor's degrees in nursing, and still others with master's degrees in nursing. This is a pretty wide time frame, and all the different degree types have been hit. When asked how much time was dedicated to eating disorders during nursing school classes, there were two distinct responses. One was 0, and the other was maybe 30 minutes. When asked how much time was dedicated to eating disorders during clinicals, all but one person said 0. And that one person responded with, "I was lucky to have a practicum at a pediatric hospital which treated eating disorders inpatient. I spent an hour or two total working with eating disorder patients." If all that's being offered for both physicians and nurses is only on-the-job training, but the trainers are not equipped to educate on eating disorders because they've never been trained either, then how can the system change? All is not lost. This is where we come in. We can provide training to those who are open to it. Many providers reported wanting more knowledge. When asked what they wanted training on, a group of residents and family physicians specifically identified wanting more information on screening criteria to be aware of, medical management, tests to order, how frequently, what to look for in checkups, how to monitor for emotional or mental well-being, management of comorbidities like anxiety, depression, and diabetes, safety of medications and eating disorders, and what activities are safe when someone has an eating disorder, like athletics. Similarly, a group of nurses identified wanting more training on how nurses specifically can effectively manage a person with an eating disorder, the best ways to speak to an individual with an eating disorder and what steps to take for referrals, and how to screen for or identify patients with eating disorders and what resources we can give them. More to come on all of this later. As eating disorder providers, one of the things we need to do is advocate for our clients. But knowing how to do this can be a challenge. So we're going to go through a few of the practical ways to do this now. The first thing we need to do as providers is educate, educate, educate. Providing education to a medical provider may be intimidating. We probably grew up being told and therefore believing that medical providers know more than we do. And while that may be very true in some instances, when it comes to eating disorders, we are the experts. The great news is that we already know what they're asking for, and we're going to get to answering those in a little bit. But if this is something that you are totally comfortable with, you may be doing it already. But if you're like me, maybe you still suffer from white coat syndrome. I know my blood pressure goes up when I go to the doctor. You'll want to take baby steps. So you can start by talking to your own providers that you already trust. You can be explicit when you tell them what you do for a living. You can make sure they know about CEUs or CME events that you know about for themselves and their office staff. You can make sure that they know how to get in touch with you if they have a referral to make. I know I've gotten calls from several of my own providers when they've had someone with an eating disorder and didn't know what to do and how to refer. If you have children, have conversations with their pediatrician about eating disorders. Maybe ask them how they screen for eating disorders. It doesn't have to be anything formal. If you're ready to dive in further, maybe you can offer your services more widely. You can personally offer to provide education to a medical provider's office. If there's a local medical school or nursing school, you could offer to give the professor a break for a day, and maybe you could give the lecture on eating disorders to the students. And you can find places that aren't necessarily in the healthcare setting, but that might be places where you can provide education. Schools could be a great place to start. School counselors and school nurses often do education series throughout the year. Sometimes they're for students, but a lot of times they're offered for parents. Having been invited to many of them, I guarantee you that at least one of them is about weight loss, maybe disguised as healthy eating. You could contact local schools in your area and offer to provide education to the parents about eating disorders to help counter the diet culture that is definitely being forced so heavily upon everyone. The other thing that we can do to support our clients is to practice what we preach. When we teach our clients to advocate for themselves, which we're going to get to in a little bit, we may be asking them to do things that make them step outside of their comfort zone. If we do the same things, it might be out of our own comfort zone as well, at least at first, but that will also allow us to support our clients with more empathy based on our own real life experiences. Speaking from personal experience, the first time I asked not to be weighed at a medical provider's office, I was quaking in my boots. I was second guessing myself and nearly talked myself out of it. I was thinking, what if they question me? I don't want to be confrontational. What if they tell me I have to be weighed? What if they look at me funny and ask me why? What if this makes them think I'm weird? What if this makes them think I've got a chip on my shoulder? The list goes on and on. But I did it. And when I simply said, no, thank you, to the medical assistant, she said, okay, and moved on. If we quake in our boots this way, our patients will too, because no eating disorder patient was ever non-confrontational. And we will be able to better help them when we've been there ourselves. It's also important to remember that the providers we see have not been educated on eating disorders. They don't know the statistics, and they don't truly grasp the seriousness of their words. If you've asked not to be weighed and are weighed anyway, or have asked not to see your weight and are given your weight in discharge paperwork, I feel that we as providers in the field have a duty to say something so we can help to protect others. I don't know about you, but I would rather be the one doing the educating than making my clients be the educators when sometimes they are just fighting to stay alive. I use the example of being weighed because it's so prevalent, and we can do a lot of good in advocating for our population if we remember and inform providers that weight is not proxy for health and should not be discussed with patients and family members unless permission is given and or concern about weight is the explicit reason for the patient's visit. When they talk about weight inappropriately, we cannot just let it go. Talking about a person's weight is not inconsequential and should not be thrown around haphazardly. The emphasis on weight in society in general and in the medical field has led to increasing rates of eating disorders, and the statistics we saw earlier, like 2/3 of girls would rather be mean or stupid than fat. I cannot tell you how many clients I've seen who could pinpoint the exact moment their eating disorder took root, and it was when their doctor started to talk to them about their weight and their diet. Talking about weight is a serious medical intervention and should involve a full informed consent. Prior to discussing it, you should be informed of the purpose of talking about it, the potential risks of talking about it, the potential benefits of talking about it, and the alternatives available. Only then should the topic be discussed. And if you have a provider like my family did, where my kid's pediatrician tried to talk to me about my daughter's BMI when she was 3 years old, it's okay to find a new provider. When this happened, I talked with him about it for a few minutes. Then when I felt like we were going nowhere, I talked at him for a few more minutes. And when he tried to leave the room before I was done, I definitely did tell him to sit back down. He ultimately told me he would make a note of it in her chart, and we decided never to go back. You should feel like an active participant in the care you are receiving. And if you don't, and the provider isn't open to repairing the relationship, it's time to move on. So now that we know how to tackle some of our own professional and personal realms, let's look at how we can help to guide our patients into being their own best advocates. If a client tells you they have a medical appointment coming up, one of the first things you can do is ask them questions about previous experiences they've had. They will be numerous, they will vary in intensity, and you will probably hear things you never imagined you would. Some examples of questions you can ask are, tell me about any poor experiences you've had in the healthcare setting. Tell me about any good experiences you've had in the healthcare setting. If I say the word doctor or nurse or doctor's office to you, what emotions does that spark for you? How do you want to be treated by your providers? If you had to go to the doctor tomorrow, in the perfect scenario, what would happen? When I've asked these questions to my clients, I've gotten all kinds of responses. Most people have had a mix of both good and bad experiences. When someone has had predominantly negative experiences, though, and you sense that they may go into a visit guarded, it can be helpful to remind them that most people in the medical profession did not go into it to hurt people. They went into it because they wanted to help. They just don't have the knowledge they need to treat someone with an eating disorder. And they can have someone else go there with them as an advocate to help them in case they're worried that they won't feel grounded. So first we ask questions. Then it's important for us as providers to educate our clients about how to advocate for themselves. We can remind them that they can interview doctors before they see them. They can write a letter to give to providers' offices, the provider or their office and staff. They can prepare their thoughts of what they want a provider to know ahead of time and rehearse it so they go in prepared. They can bring someone else with them. They can sign an ROI for you, their eating disorder provider, so you can talk to the medical provider before they go. And they can end a relationship with a provider if it's not helpful or is outright harmful. Clients with eating disorders will be at different stages and comfort levels in their recovery. Some will be long into their recovery and very comfortable having direct conversations with providers. Others will be much more reluctant or hesitant. One thing that's important to always remember is that if they aren't comfortable with it, it is not the patient's job to educate their provider. Their job is to inform their provider about their eating disorder and how they want to be treated, nothing more. That's why we provide the education. The other thing to really reinforce is that the patient has to tell their provider that they have an eating disorder. So many times I've heard conversations that go a little bit like this. GI specialist. So what's bringing you here today? Patient. I have really bad constipation and my stomach really hurts all the time. I know something's wrong. I've tried everything and so far the only thing that's helped is cutting out gluten. GI specialist. Is there anything else going on that I should know about? Patient. Well, like I said, cutting out gluten has really helped. I was doing some research online. I think maybe I have IBS. Do you think that could be it? or a patient at a cardiologist's office. So what's bringing you here today? Patient. My PCP told me to come because my heart rate's low, but I run 6 miles a day, so isn't that normal? Plus, everyone in my family has a low heart rate. It must be genetic, don't you think? Cardiologist, it could be. Tell me about your diet. Patient. Oh, I eat all the time. I eat a lot of protein. I really love fruits and vegetables. I think my diet is pretty balanced. What's missing from both of these scenarios? Oh, yeah. And I have an eating disorder. No matter what, someone with an eating disorder needs to include that in their history when they speak to a provider. When someone is just entering recovery, mentioning their eating disorder needs to be one of, if not the very first thing that they do. It's a tiny seed that needs desperately to be protected. And since we know that eating disorders don't always look stereotypical, mentioning the eating disorder is even more important. And when someone is further along into their recovery journey, they still need to mention it. It's part of their medical history. Just like someone who had breast cancer with lymph nodes removed needs to tell every provider they see for the rest of their life not to do a blood pressure or blood draw on certain extremities because it can be detrimental to their health, someone with a history of an eating disorder needs to let providers know because inappropriate comments can be detrimental to their health. One of the things I always like to do when I'm presenting is to make sure that everyone leaves with some very practical things that they can put into practice today if they want to. So here are some resources that you as providers can utilize. Remember, the medical providers already told us what they wanted to know. So first, they wanted to know, are there screening tools to help identify eating disorders? Yes, there are. And here are 3 of them. Websites to access all of them are in the references section of these slides. So the first one is the ESP, the Eating Disorder Screen for Primary Care. It asks 5 questions. Are you satisfied with your eating patterns? Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family suffered with an eating disorder? Do you currently suffer with, or have you ever in the past had an eating disorder? A no to question 1 is classified as an abnormal response. A yes to questions 2 through 5 is classified as an abnormal response. And any abnormal response indicates that the client may need further assessment. There's also the SCOFF, which uses 5 questions based on the acronym SCOFF. So the S is for sick. Do you make yourself sick because you feel uncomfortably full? C for control. Do you worry you have lost control over how much you eat? O for 1 stone. Have you recently lost more than 1 stone in a 3-month period? And yes, this was developed in England, and 1 stone is the same as 14 pounds. F for fat. Do you believe yourself to be fat when others say you are too thin? And F for food. Would you say food dominates your life? An answer of yes to 2 or more questions indicates the need for a more comprehensive assessment. A further 2 questions with the SCOFF have been shown to have a high sensitivity and specificity to bulimia nervosa. These questions are not diagnostic, but indicate further questioning and discussion may be required. Those 2 questions are you satisfied with your eating patterns? And do you ever eat in secret? There's also the EAT 26. It's a 26-question questionnaire that asks questions on a 6-point scale. That is a lot of the word question in a very short phrase. They're graded or scored as always, usually, often, sometimes, rarely, and never. This one is longer, so I'm not going to go through every question, but it does ask people to rate statements like, I'm terrified of being overweight. I feel extremely guilty after eating. I feel food controls my life. I have impulses to vomit after meals. It also asks behavioral questions about behaviors in the last 6 months. It asks about binging, vomiting, using laxatives to control weight, exercising more than 60 minutes a day, losing more than 20 pounds in the last 6 months. The scoring for it is done on a 0 to 3-point scale for questions 1 through 26, and a score over 20 indicates that further evaluation should be conducted by a trained professional. On the behavioral questions, a yes to certain responses indicates further evaluation should be conducted by a trained professional. One of the things that we can always remind PCPs of is that their main goal in this screening process is to identify individuals who might need further evaluation. They don't necessarily need to know the intricacies of how to treat the eating disorder, just how to identify it, and then how to refer to specialists. But what if we find that diamond in the rough and they want to know better how to manage eating disorders within their practice? Unless you are a medical provider who is also an eating disorder expert, you do not need to know how to treat the medical complications of eating disorders yourself. Two great resources to offer to providers who are interested are, one, the book Sick Enough by Dr. Jennifer Gaudiani, and two, the book Eating Disorders, A Guide to Medical Care and Complications by Dr. Philip Mailer and Dr. Arnold Anderson. Both of these books are comprehensive guides that providers can use as resources to help in the medical management of their patients. Dr. Gaudiani's book is a little bit easier to read and can be more easily digested by both providers and non-providers. I actually often recommend this book to family members who are curious about the medical side of eating disorders. Dr. Mailer's book is definitely geared more towards medical providers. It's harder to sit down with a cup of coffee and read cover to cover, but it is full of extremely useful information. But as a nurse who has been in this field for a long time, I couldn't possibly not talk about a few of the medical pieces that you could offer to providers who ask. First, every body system can be affected by an eating disorder, but the body is also resilient and can bounce back if the eating disorder is treated. In the acute phase of an eating disorder, doctors will want to look at labs, specifically the CMP, magnesium, and phosphorus. They'll also want to look at weights and vitals on a regular basis. A DEXA scan is also important to understand a patient's bone health, because with eating disorders, we see bone loss all the time. If something is abnormal, interventions and maybe supplementation could be necessary for a short period of time. But then once stabilized, things should remain stable unless behaviors start again. One example of this is hyponatremia. So hyponatremia, or low sodium, is something that can show up on labs when someone is engaging in water loading. The body is so full of fluid that the salt content in their bloodstream gets diluted and their sodium level drops. This can lead to confusion, seizure, coma, and death. When it's mild, it can typically be treated on an outpatient basis with the intervention of a fluid restriction. If someone's intake is reduced to about 2 liters of fluid a day, their sodium value should normalize quickly, and that's the only intervention that may be needed. Once the sodium level normalizes, as long as the water loading behavior has stopped, it shouldn't become abnormal again. Another example is hypokalemia. So hypokalemia is another fancy way of saying low potassium, and it's something that can show up on labs when someone has been engaging in purging. A low potassium, when it's severe, can lead to cardiac abnormalities, arrhythmias, and death. If it's mild, though, it is typically asymptomatic and can be treated outpatient with supplementation. Once the supplements are given and the potassium level normalizes, just like with sodium, if the behaviors have stopped, the potassium should not become abnormal again. On a physical exam, it's important to assess for orthostatic hypotension and symptoms of dizziness upon standing. Some patients are orthostatic by heart rate, others by blood pressure, and some by both. In some patients, this may cause a lot of dizziness when they stand up, and in other cases, it may be totally asymptomatic. Still other times, the vitals might look perfect, but the patient is highly symptomatic. This is why we treat a person and not a number. When someone is experiencing dizziness upon standing, they are at increased risk for falls, and depending on their bone health, this could be very dangerous, not to mention that they could fall and hit their head, which we also want to avoid. Another thing to look for is edema in the extremities. This can happen with refeeding syndrome or if someone abruptly stops purging. It's possible that when someone experiences this swelling, that they are also gaining weight rapidly due to the fluid retention. If this happens, it's important to check a phosphorus level in the event that it's being caused by refeeding hypophosphatemia. Lung sounds are also important to check. If someone is experiencing that refeeding hypophosphatemia, in addition to experiencing swelling in their extremities, fluid can build up in the lungs, which can be extremely dangerous and deadly. Bladder fullness is something that we will often ask primary care providers to check for us. Clients with eating disorders may experience, especially if weight restoration is needed, urges to manipulate their weight. One way they can do this is by water loading and then holding their urine. If a provider has any suspicion of a patient holding their urine, palpating the bladder or performing a bladder scan may be indicated. There are a lot of times that within health that we rely on PCPs to help us with this. If we're suspicious that a patient is manipulating their weight in a virtual setting, we'll have them go to their PCP for a weight check. We rely on that PCP to check the bladder and ensure we are getting an accurate weight. They can also look for parotid gland swelling. This can occur when a patient stops purging. When someone has been engaging in purging via vomiting, their parotid glands, which sit towards the back of the jaw, will be producing excessive amounts of saliva. Then the act of purging releases that saliva. When someone stops purging, the extra saliva continues to be produced for several weeks until the body can downregulate itself. But if there's no trigger to release the extra saliva, then it will continue to sit in that parotid gland area and will cause swelling, which can be very painful. It can be difficult for someone to open their mouth. It can be difficult for them to chew. And if that happens, sometimes sucking on a hard candy can be helpful, as can heat or cold, whichever they prefer, and anti-inflammatory medications, with the reinforcement that in a few weeks, it will all resolve itself. And of course, the bowels and GI. With eating disorders, the GI system often slows down, something called gastroparesis. As food becomes normalized again, though, they may need some mild intervention, like an osmotic laxative, because the bowels are not going to speed up as quickly as the food may be entering, so that clients aren't so uncomfortable when we are asking them to eat potentially 6 times a day. While some of the complications associated with eating disorders are more tied to a particular diagnosis than another, like hypokalemia being associated with purging, the majority of them occur with any type of eating disorder, regardless of body size. When it comes to medications and eating disorders, I leave that to prescribers. What I can say is that there are times when doses may need to be adjusted due to the eating disorder, but pharmacological intervention can be extremely helpful and effective when treating an eating disorder. They also asked how to monitor for emotional or mental well-being. Since most of you here today probably fall into the non-medical category of provider, you may be able to answer this question way better than I can. Remember, The medical providers are not therapists. They probably had a few lectures on therapeutic communication, and that's about it. Here are some things I would recommend, but please feel free to add to this list. Always encourage them to ask lots of questions, and even more importantly, to listen to the answers. They can ask about depression. They can ask about anxiety. They can ask about eating disorder behaviors, how and when they show up. They can ask about self-harm. They can ask about suicidality. They can ask about a client's support system and if it actually feels supportive. Medical providers want to be able to intervene and see results. So it's important to remind them that when they're asking about all of the above, they're not going to fix things. Their job in that moment is to listen and validate just how difficult this process is. They need to make sure that the patient knows that they are truly cared for and that they will work together with the patient to get them the support that they need. This could also be a great time to make sure appropriate referrals have been made and to remind them to collaborate with other team members when they can. They also asked about management of comorbidities like anxiety, depression, and diabetes. And this is where referral to specialists can be extremely important. Some patients can recover from their eating disorder without any kind of pharmacological intervention, but many need it. Eating disorder-informed psychiatric providers can help to manage both the anxiety and depression, and great therapists can help with that also. Medical comorbidities can add a huge layer to eating disorder treatment. Diabetes in particular adds enormous complexity to eating disorder treatment and should be managed in conjunction with a larger team. It's important to make sure that the patient has an endocrinologist on board that is aware of the eating disorder and not minimizing of it. They need to make sure that there's a diabetes educator on board that's aware of the eating disorder and that there is a dietitian on board that is comfortable navigating both the eating disorder and the diabetes. But it might not be diabetes. It could be any medical comorbidity. A few others I can think of are hypothyroidism, autoimmune disorders, GI disorders, and allergies. In any of these cases, team collaboration is key. All disciplines need to be aware of the eating disorder and need to be comfortable treating the comorbidity in conjunction with the eating disorder. If you have an opportunity to speak with a PCP, an important diagnosis to be aware of is something called euthyroid sick syndrome. If a patient has true hypothyroidism, prior to being seen by an endocrinologist, the PCP may begin to manage it on their own. In the case of an eating disorder, what we often see on lab tests is a thyroid that looks sick by a low free T3 and or a T4, but is actually perfectly healthy, evidenced by a normal TSH. The thyroid is the driver of the metabolism in the body, and if someone is not nourishing the body properly, the thyroid can downregulate itself. Rather than having that PCP start somebody on any kind of thyroid medication, we need to remind them that what that patient needs is food. With proper nutrition, the thyroid will usually upregulate itself back to normal within a few months. Over and over again, we see PCPs and endocrinologists put someone with euthyroid sick syndrome on thyroid medication, which does speed up the metabolism, when the last thing someone with an eating disorder needs is a faster metabolism. And finally, they wanted to know what activities are safe when someone has an eating disorder. The short answer is it depends. But here's a longer thought process. First, we go back to asking questions. First, what has the patient's relationship with movement been like? If you ask that question directly, even if movement is something the person has struggled with, the answer you will get will be something like, I love movement. I've just always been a very active person. Instead, you can ask things like, How much time do you spend exercising every day? Do you ever exercise in anticipation of food? Or will you be eating the food you'll be eating, or to make up for food you have already eaten? If you are sick or tired or really not feeling up to it, do you make yourself move anyway? The patient's responses will hopefully give us a better picture of what movement looks like in their life. It's also important to ask about what messages they've received about movement. For some, similar to food, movement in their family or their culture may have taken on a moral quality. Lots of movement equals you're a good person, or not enough movement equals you're a bad person. For other individuals, especially if they are living in a larger body, they may have been shamed when going to the gym, or been told that their lack of movement is what caused their issues or their moral downfall, leading them to have a very strained relationship with movement. The other thing that should always be assessed is someone's bone health. This is done through a DEXA scan. If someone has low bone density, that individual is at higher risk for fracture, and their high impact activity needs to be removed. The way I explain this to patients is when I worked in a hospital, I worked on an orthopedic floor. I would have my little old ladies come in with a hip fracture, and I would always ask them, so tell me, did you fall and break your hip, or did your hip break and then you fell? And most of the time, the answer was the latter. Their hip broke and then they fell. And this is the epitome of low bone density. When someone is nourished, high impact activity and resistance training can stress the joints and encourage bone deposition, making the bones stronger. However, when someone has an eating disorder and is actively restricting, movement can have a negative impact on bone health. The same high impact activity that's helpful to the bones in a healthy individual has the opposite effect on someone who is malnourished and restricting, regardless of body size. Though this may be shocking in the wider non-eating disorder medical community, when in doubt, even temporarily, always recommend limiting movement. It's important for patients to have that myth debunked that the only way they will be healthy is if they move. We aren't telling them you will never move again. We simply want them to see that you can not move and your body will still be okay. It will not explode. We want them to see that their worth is not defined by their ability to move. And we want them to know that they can take movement at their own pace, and we will not be shoving weight loss down their throat any way we can. Once someone is nourishing properly and has weight restorative necessary and is ready to start exploring movement, it should never be encouraged as a behavior for weight loss or body modification. Movement should be for all of the things it can do for us. It can help to relieve anxiety, it can give us energy, it can be a way to connect with others, and it can be joyful. The thing to remind a medical provider is that movement can be a very sensitive topic for most eating disorder patients, and they always have to treat it delicately. In addition to resources directed towards all of you, our amazing providers, I also want to make sure that you are equipped with resources for your own clients. So I mentioned briefly before that a patient can interview a provider before seeing them regularly. But what kinds of questions do you ask? Here are some ideas for a jumping off point. Interviewing a doctor can be formal or informal. It can happen as a pre-visit meeting or during your first appointment with them. The aim is to get to know them as a human and as a provider, and to make sure that you feel comfortable working with them to maximize your health. So you could ask things like, what inspired you to become a doctor or a nurse practitioner or physician's assistant? How do you ensure effective communication with patients and their families? How much time do you spend with each patient? If I have a question and call the office, how long would it usually take you to get back to me? What are your views on weight and BMI? And would you be okay with me not being weighed unless medically necessary, like for dosing of a medication? How comfortable are you treating someone with an eating disorder? And what are your thoughts on eating disorders affecting more than skinny white females? Is your office staff eating disorder aware? Are you open to collaborating with other members of my eating disorder team? Those are just a few examples of starter questions you can ask, but you can be more detailed and go more in depth if you want. You could ask specifics like, what training did you receive on eating disorders? What is your food philosophy? How often do you screen patients for eating disorders in your practice? And if they screen positive, what's your next step? The questions you ask should hopefully point you or this patient in the direction of this provider will be a good addition to my team or not so much. And if it's not so much, they don't have to stay. The job of medical providers is to take excellent care of us. And if a patient feels like they might not do that, then they aren't the right fit. Another question or another thing that we often recommend to patients is that they write a letter to their provider. But what could they include in that? Well, it all depends on what you're trying to do. It's something that could be written ahead of time and sent ahead of time, or it could be written ahead of time to be given at the time of the visit. It could be for everyone in the office or only the provider. It could be something done in preparation for a visit just to get thoughts in order without ever having an intention of sending it or giving it to anyone. It can be sent after the fact if you have a negative experience. It might also be a rage-filled letter that never gets sent as a way of getting things off your chest. And hey, maybe one day it does get sent. It can include any request that you have, an explanation of your diagnosis, a preemptive addressing of things you're worried about, like maybe minimizing of the eating disorder or getting weight loss recommendations, an explanation of what occurred during a visit and why it was detrimental. I'm actually going to read through a few examples of letters now so you can see how letters might be worded. All of these examples and a few more are going to be available to everyone, to all Summit participants on their dashboard. So no need to take notes. Feel free to use and modify these templates in your own practices and offer them to your clients whenever you feel like it's appropriate. So the first is a letter of that we're writing to a provider before they see a patient. Dear provider, thank you for taking the time to see me, and thank you for taking the time to read this letter. I have had some experiences with past providers that I am hoping to prevent and want to take a moment to share some of my history with you. I currently have, or maybe had a history of, an eating disorder. More specifically, I have, insert your diagnosis. I have been working hard to recover from this disease, and I know that I will overcome it. In order to do that, I need the support of all of my providers. Despite eating disorders having a reputation for being a swag disorder, they affect every body type, race, gender, and sexual orientation, and they are deadly. Please know that even if you have preconceived notions about what an eating disorder might look like, and I don't fit that mold, I do have one, and it is serious. So I want to ask for a few things. 1, please do not weigh me unless there is a medically necessary reason for it, like needing to determine the dose of a medication. And if you do need it for a particular reason, please do not share numbers with me. 2, please do not make dietary recommendations to me. My eating disorder can take these and run with them. I have a dietitian who is helping me with my meal plan. 3, please do not glorify any of the things my eating disorder has done to my body. These are not the result of healthy behaviors. This includes insert different things as appropriate. My low heart rate, my low blood pressure, my recent weight loss, things like that. 4, please do not attribute any problems you see to my weight, fat broken arm syndrome. I want to make sure that when I see you, we are addressing the issue I am coming for and not my weight. 5, please do consult with other members of my team. They can fill you in on more of my history and would value your input as well. Please do be slow and thoughtful with me. Like I said, I have had negative experiences in the past and want to do things differently this time. 7, please do share this with your office staff. I so appreciate when everyone on your team is aware of how I would like to be treated. Thank you again for working with me and for being willing to include me and my needs into my treatment plan. If you have any questions and would like to speak to other members of my team, you can reach them at, then you put in other team members' names. Sincerely, patient. Another letter, this is an example of a letter that's sent to a specialist. This one is coming from the viewpoint of the provider on behalf of the client, but language can always be modified and moved around. Dear provider, my name is Chrissy, and I am the Chief Health Officer at Within Health, who is currently working with, we'll call her Mary. I am writing this letter at the request of Mary to inform you that she is being treated for an eating disorder. She attends Within Health and is working towards recovery. She has shared with me that she is extremely nervous to attend your medical appointment. She has been told by endocrinologists and other medical providers in the past that she must lose weight or diet to manage her health. This advice, though well-meaning, has had the opposite of the intended outcome and has led her into further reliance on her eating disorder behaviors. For over half her life, Mary has been caught in a vicious cycle of restricting her food intake, binge eating, abusing substances, and purging. In this cycle, her weight has gone up and down and continues to be an area of fixation and hyperfocus in her life. Given this, I urge you and your staff to please avoid discussions with this patient involving weight and diet, as these are highly triggering topics to her eating disorder and historically results in restriction, binging, and purging, and ultimately weight cycling, which results in further weight gain and compromised health. I ask that if you need to take her weight, you do so with her turned backwards so she does not see it, and that the number not be discussed with her or provided to her on the discharge paperwork. Mary, her therapist, and I are working on weight-neutral approaches to manage her health in order to help her exit the eating disorder cycle and fully recover. Thank you for taking the time to read this letter and for helping to ensure health, safety, and further the process of recovery for this patient. Please contact me with any questions. Sincerely, provider. And this last one is an example of a letter that is sent post-visit. This happens also to be written by a provider on behalf of a patient, but again, language can be modified. And this letter in particular was sent to the provider that told my client, Mary, from our vignettes, well, at least you're thin. Dear provider, my name is Chrissy, and I am the Chief Health Officer at Within Health. One of our patients saw you in your office this week for a consultation. This next part is what could be modified for the situation. I wanted to write to you so you could understand the impact that your words had on this patient and potentially others as well. During the visit, among other things that you said, you told her, at least you're thin. This is an individual whose thinness has had her on the brink of death for over 30 years, and she has been fighting tirelessly for the last 2 years to combat the incessant thoughts that she has that food is dangerous, and the only way I'll be safe is if I'm small and disappear. Fighting these thoughts is hard enough in a world that tells us every day, day in and day out, that nothing tastes as good as skinny. But when those beliefs are reinforced in medical offices, it makes that fight even harder. When this patient came to me later in the day, your comment was the first thing she told me about, and because of it, she wasn't able to bring herself to eat anything until dinner. I am certain that you had no idea of the seemingly benign comment you made would have such an impact, which is why I wanted to bring it to your attention. According to statistics, almost 9% of the population suffers from an eating disorder at some point in their lifetime. And in a 2008 study, over 75% of women suffered from disordered eating. Additionally, only 6% of people diagnosed with an eating disorder are classified as underweight, which means we cannot tell if someone is suffering just by looking at them. Eating disorders are hidden and they are deadly. Part of what I do on a daily basis is try to bring awareness to this issue, especially to the medical community, in the hopes that as providers, we can change the way we speak to our patients about weight in their bodies. My hope is that by bringing this awareness to you, you would be open to thinking about the issue, and if there are ways you can change how you address your patients' bodies. If you have any questions about this or would like to discuss this further, please feel free to reach out to me directly. So those are a few examples of letters. The last thing I want to discuss briefly is common ways that I'll refer to as eating disorder reinforcers are often shared with clients, even when the provider is well-meaning and it's done totally inadvertently. So the first one is discharge paperwork. It's a doozy. When a patient visits with a provider and finishes with that visit, it can be at a doctor's office, an urgent care, an ER, they're typically given discharge paperwork that includes a post-visit summary that cannot be modified. As the patient is walking out the door, it's handed to them for them to keep and peruse at their own leisure. Unfortunately, it almost always includes vitals, including weight. So even if someone asked not to see their weight during a visit, and that's respected, it might just be handed to them when they are walking out the door. In many facilities, the discharge paperwork automatically generates additional information like dietary recommendations and weight loss recommendations and activity recommendations. Everything we ask the provider not to discuss still makes it into the patient's hands. DEXA scans. I've actually heard recently that this is changing a little bit, but in some places, but DEXA scans are notorious for revealing a client's weight to them. When a client gets a DEXA scan done, they will be weighed as part of the data that's collected for interpretation. The patient can go through all of the steps of asking not to see it, and that can all be respected. But then when they lie down on the table, there's usually a computer screen right above them, and right there front and center is their weight. Patient portals are another doozy. So similar to discharge paperwork, everything post-visit gets uploaded into a patient's portal. So patients have access to all of their information, including weight and diagnoses. And if you as an outpatient provider communicate with the medical provider, sometimes that communication gets uploaded as well. So make sure that whatever you say in any kind of written communication, it's something that you know the patient will likely see. These instances may not be totally avoidable, but if we prepare our clients for what might happen and the impact it could have on them, the more willing they might be to throw that paper away without reading it, turn their head or close their eyes, or just not log into their portal. Eating disorders are secretive and full of shame and guilt. My hope is that providing you all with these resources, your clients will be able to find medical providers that are thoughtful and empathetic towards them, and that some of the secrecy and shame they feel can be removed. I'll take a moment to finish with this quote from Maya Angelou. I learned a long time ago that the wisest thing I can do is be on my own side, be an advocate for myself and others like me. Thank you all so much for listening today. And if there are any questions, I'd be happy to take a few minutes for that. Jamie?
Thank you, Chrissy. That was an excellent presentation. And we do have a question for you. The question is coming from an anonymous person, and they are asking if providing the letters and the template for that communication with providers, have you seen where clients feel more empowered and comfortable advocating for themselves?
Yes, I have. So I think a lot of it comes from clients learning how to prepare themselves. So if they spend some time in anticipation, preparing themselves for what they want to say, they really do feel empowered. If they have given that letter ahead of time, I've had patients who will hand it to every single person that they come in contact with, from the person that they check in with to the medical assistant, to the nurse, to the doctor, to the next doctor that's sitting in the next office. And they feel really good about it because they know that they have resources in their hand that tell exactly what they're looking for. So I think that they do feel really empowered and much more comfortable when they actually encounter the situation.
Yes, and I can speak to this, Chrissy. We've had the pleasure of working together for years. And I think giving our clients that power to advocate for themselves, a lot of them, this is the first time that they've ever been in those positions to ask those questions, to set those limits with providers. You mentioned that there is a sense of anxiety that we get when we're in the doctor's office, and we want to be respectful. We want to listen to the doctor because that's what we've been conditioned to think, that if the
Mhm.
doctor says so, then that's what we do. But this has definitely opened up a variety of ways that our clients can continue to advocate for themselves. I think we have time for one more question, and this person would like to know, do you find that in a remote setting, connecting with clients and giving them the power to advocate has been something that is different than in traditional brick and mortar?
I think that I don't know that I've noticed a huge difference with it, because in both situations where I've worked, we've been either sending someone out into the community from the local residential or PHP, sometimes by themselves, and in a virtual setting, also potentially by themselves. And so I haven't necessarily seen that there's a difference from the in-person to the virtual side of it. Um, what I have noticed is that in our virtual setting, one of the things that we have a lot more ability to do is connect with more providers. Because when we work in a local program, typically there's a very small community of providers that we've vetted, that we feel comfortable with, that we know who we're sending to. And in the case of a virtual program, it's providers all across the country. You never know who's going to pick up the phone. You never know who it's going to be, what their philosophy is going to be. And so we've been able to really spread the knowledge in a different way and have seen so many more things. And so I would think that that's probably the biggest difference that I've noticed with in-person versus virtual.
Thank you so much, Chrissy. We appreciate all of this wonderful information. And to our attendees, you will have a break and we will go into our next session at 1:30, and all of the times are in Eastern time. So we will go into our next session at 1:30, and it is going to be an amazing panel discussion where they will be discussing addressing mental health challenges in today's college students. And I can just tell you that this panel is filled with amazing professionals who have a wealth of knowledge, and this conversation is definitely going to be stimulating and interesting, and hopefully you will walk away learning just a little bit more than what you came. Also, please remember to check your CEO dashboard for all of the scheduled events that will be happening today and for the remainder of the summit. If you have any questions, don't hesitate to contact. And thank you all so much, and we will see you later. Have a good day.